Our third panel will illuminate a vital topic. There is a missing link in the prevention and management of cardiovascular disease. I believe that most of us gathered today participate in discussions about healthcare quality improvements or systems changes to prevent cardiovascular disease, and we work on policy changes to bring about such system changes, and we work on the socioeconomic determinants of health. But there are three significant contributors to cardiometabolic disease that get a lot less attention. They are depression, stress, and anxiety. Together, they are the missing link. These mental health conditions lead to heart disease, stroke, and the risk factors and make them worse. In fact, depression, stress, and anxiety are major drivers of obesity, smoking, heart attacks, and strokes, yet they fly under the radar. This panel will help us raise the priority on depression, stress, and anxiety prevention and management. Joining me on this panel are Cheryl Woods Giscombe, the Levine Family Distinguished Scholar of Quality of Life, Health Promotion, and Wellness at the University of North Carolina at Chapel Hill. Dr. Giscombe is also the Associate Dean of the PhD Division and Program in the UNC School of Nursing. And Bernadette Melnyk, the Chief Wellness Officer for The Ohio State University, Dean of the OSU School of Nursing, and Professor in the School of Medicine. Dr. Melnyk is the National Forum's Secretary-Treasurer. Dr. Giscombe, Dr. Melnyk, thank you for joining us.
Thank you.
Happy to be here.
Let's begin with an overview of the connections between mental health, obesity, diabetes, cardiovascular disease, and therapeutic adherence. Bern, how are these conditions linked?
For one, we have a strong body of evidence that links mental health problems with cardiovascular disease. Today, we have a mental health pandemic inside of the COVID-19 pandemic. Recent studies that have been published report that 1 out of 3 people across this country are suffering with clinical depression or anxiety. The other thing that's going on right now, people are attempting to cope with COVID with unhealthy behaviors, such as unhealthy eating, declines in physical activity, and increases in alcohol use. What that's going to mean 2, 3, 5 years downstream is even higher rates of high blood pressure, diabetes, and cardiovascular disease.
Are we talking about just adults here, or are there other ages that are affected?
It's across the lifespan. In fact, a recent study that came out that looked at healthcare claims in teenagers showed a 90% increase during the pandemic for such mental health issues like clinical depression, anxiety disorders. So this problem is not going away. It's become, again, a pandemic inside of a pandemic.
Yeah, I think the way you're framing that is really important. And Dr. Giscombe, Dr. Melnyk just talked about that pandemic inside the pandemic and how the COVID pandemic has made the mental health pandemic even worse, which is feeding into the cardiovascular disease pandemic. Is the problem here that we don't know how to screen and treat people for depression, anxiety, and stress? And if that isn't it, then what's going on?
That's a great question, because what you're doing is getting at the heart of the matter. If we know this, how can we prevent it, ameliorate it, and help people have better health and well-being? And one of the issues is the need to talk about it more the way we're doing now. This is one of my favorite topics to discuss. Stress and coping is my area of research. I'm a social and health psychologist as well as a psychiatric nurse practitioner. And those things together allow us to understand the problems and the mechanisms and then reach out to people, families, communities to address it. And so a major challenge is assessment, as you identified. There has been discussion about if you open that can of worms to ask people about their stress, their mental health, then do we have the capacity, the resources to address the responses we will receive? So that's one challenge. The other challenge is what is known as the stigma of mental health issues. So will people feel comfortable enough? Do we feel comfortable enough as providers to ask those questions and then make people feel okay with saying that they're not okay emotionally, psychologically? And so assessment is a key issue. But the great thing is that now that we know about the pathways between stress and mental health and health behaviors, as well as the physiological responses that cause cardiovascular disease, now we know that. We know also that there are evidence-based stress management and mental health interventions that can help communities, and as Dr. Melnyk said, across the lifespan, prevention with children, treatment of children, and on up to older adulthood.
Cheryl,
That is such a good point. Go ahead, Bern.
I'm so glad you mentioned prevention, because currently we live in a sick care, crisis care focused healthcare system. We are always going to need great, acute, critical crisis care. But our country spends more money on healthcare than any Western world country, yet we rank in the bottom for population health outcomes. I believe one of those big reasons is because we only invest 8% of our healthcare spending in prevention. So we've got to shift this paradigm, especially with our children. As you mentioned, we have evidence-based intervention programs that we know are successful, but it still currently takes, the newest study says, 15 years to translate evidence-based interventions into clinical practice to improve care. We have got to close this research practice time gap.
Absolutely. And I'm struck, as you say that, by the fact that that actually represents an improvement over just 5 to 10 years ago, where it's actually faster, and yet it's totally unacceptable. So I think you make a great point there, Bern. And of course, you were echoing the messages that we heard from the first panel about how we spend disproportionate resources in this country on the acute, the emergency treatment, the rescue treatment, which we're very good at, but at the great expense of people's well-being. So I'm so glad that you reinforced that point. Cheryl, are mental health screening and treatment delivered to all of the people who need them?
I would answer that with a no. And we are moving in the direction to educate primary care providers more to be able to do that effectively. And the key word is efficiently, because time is actually often not a virtue in the clinical setting. And so helping those providers to have that ability to ask those essential questions with the people who trust them, the primary care providers, and then also consider having what we call integrated behavioral health care so that we can have mental health providers in primary care settings. But we don't have to wait for people to go to the physician's office or the nurse practitioner's office or the health care provider's office to get that assessment. For example, one report just was forwarded to me yesterday from the Rosalind Carter Foundation about workplace caregiver stress. So people who are in the workplace who are caregivers to family members and friends, and their self-assessment of their stress and how it's influencing their health. So as we know, we have an expert right here on workplace well-being. That's an opportunity to help all people who work, who are employed, to have access to mental health screening, mental health support, but also that prevention in terms of a caring and compassionate environment. Because social connection, feeling valued, feeling like you have flexibility to care for your family and yourself is essential to resilience in the midst of stress, because we can't avoid stressors. They exist. And there's a concept called network stress, which is often overlooked. And as Bern said, we're in a pandemic within a pandemic. So right now, many of us are dealing with multiple layers of stress because we have this stress related to the stress our loved ones experience, our co-workers experience. You can't turn on the news without hearing stressful stories. And so there needs to be a paradigm shift in terms of creating cultures and environments that are loving and compassionate and caring. We're human beings and we can do that together. It's really important. We'll do a lot to change that pathway between stress, mental health, and cardiovascular risk.
So, Cheryl, you just talked about workplaces as one touch point for bringing about change. And I suspect that ties back to your earlier point about stigma or destigmatizing
it does.
Care. Is that right?
Yes. The more we talk about it, the more it normalizes the fact that this can be part of life and that we can do the things necessary to support people so they don't have to be suffering in shame or with guilt and in silence. So
I think that's such an important point here. And I hear that as being kind of patient or consumer focused. Bern, what about in the clinical arena among clinicians? Is there stigma there surrounding not only their own mental health, but dealing with their patients' mental health needs as well?
Yes, I think there is both. On the clinician side of things, and we have to look at clinicians as a population too, at very high risk for cardiovascular disease and comorbid mental health issues. My latest studies are showing burnout rates of 50 to 60% in clinicians, high rates, 40% depression, 50% clinical anxiety, hypertension. So this clinician population is super important. If our clinicians are struggling with their own mental health, it's going to be character building for them to focus on the mental health of their patients. I served on the United States Preventive Services Task Force for 4 years. When I was on the task force, we changed our recommendation for screening 12 to 18-year-olds for depression. So the guidance is to screen. But I will tell you, as a psychiatric nurse practitioner, I do so many mental health workshops for providers, how to better screen for, identify, use evidence-based management for depression and anxiety. A common reason providers still aren't doing it because the recommendations state this should be done when systems are in place to deal with these problems. And Cheryl brought up a lot of times there are not systems in place. Now, the ideal is to have the integrated mental health providers in primary care. But a lot of places don't have them, especially in our rural settings. But I think what people are missing is the fact that, and here's the other thing I hear, unless we get reimbursed, we're not going to do this. But CPT codes exist for screening. They exist for cognitive behavior skills building programs like I have developed over the course of 28 years of my career. And non-psychiatric providers can deliver these evidence-based interventions in primary care and get reimbursed for them. We've just got to get the word out, and we've got to educate both learners and clinicians how to do this in practice.
Those are excellent, excellent points. The financial model has to be there. It is there, and people need to know about it. And in addition to that, finding ways to help have more assessment and treatment in schools as well. Those CPT codes exist for mental health providers, for primary care providers. People can be placed in federally qualified health centers. That's one of the projects I'm working on now. A federally funded project where we are trying to design a model of tele mental health where there are more psychiatric providers, psychiatric nurse practitioners to be specific, who are literally on call to be available to serve as consultants when the primary care providers need them, need additional support in the mental health assessment and treatment. We haven't talked about this yet, but both of us have interest in integrative and holistic approaches like mindfulness meditation. And another challenge with mindfulness is also the cost. Mindfulness is very costly to become trained in mindfulness and to take a mindfulness course. But there are also very creative ways in which mindfulness can be implemented to people across economic across economic strata, so it can be accessible to all people. It's completely evidence-based across the lifespan and for prevention as well as treatment of stress-related health conditions. And our research team right now is implementing a culturally sensitive mindfulness intervention for African-American women who are at risk for cardiometabolic conditions, and we're delivering that virtually. So we're trying to figure out how do we translate these research findings, as Bern mentioned, into practice so people can use them and have a better quality of life.
So I'm struck by, it seems to me that often when we're talking about prevention not reaching people so they're not benefiting from it, incentives are an issue there. And in a lot of cases, perverse incentives that are built into the system to favor the acute care that you talked about earlier over preventive care. But this is a case where, if I'm hearing you correctly, you're saying reimbursements are available, the codes exist, so incentives are there, it sounds like to me, maybe I'm missing it, you can correct me if I'm wrong, but I'm wondering, is there something else to it here? Is there another hump that we need to get over? And if so, what is it?
There are two things that are coming to mind for me. One is how healthcare providers are educated. So healthcare providers don't always receive information about the stress. They may have information about stress physiology, but not so much about how stress influences cardiometabolic risk factors and other chronic health conditions. But there's literature in that, and we can change that right away by changing our nursing, medical, even dental curricula. I spoke at a dental school, and that's an also excellent opportunity. You think about the relationship people form with their dentist, how often they go to the dentist. We don't often think about integrating behavioral health in the dental office, or at least helping dentists to understand the need to have mental health resources in their practice so they can give them to their patients and families. So if we educate our health profession students about these pathways, about these interventions, and Bernie just gave me an idea about how to pay for them, because I co-teach a class with a colleague in the School of Medicine, mindfulness and self-compassion for health professions. We teach nursing, public health, medical students, and we're hopefully opening up to more health professions this spring. We teach them about the evidence. We teach them about their own self-care. We teach them so they can disseminate this information to their colleagues, but we have not taught them about how we teach them how to integrate it in practice, but not how to think about payment models for it. And that is one of the humps. So we're trying to equip healthcare professionals with students with these concepts and ideas and solutions. And we're not the only program that has such a course. These kinds of things should not be electives. Right now, our course is an elective. It's the kind of thing that should be central to health professions education for us to really make a dent in this.
And in that context, Cheryl, you just identified nurses, physicians, and dentists. I love that you brought dentists in. What about, is there a role for pharmacists who have so many more touches with patients or people? Is there a role for community health workers? Are there others who need to be brought up to speed similarly and integrated into the team?
I would say all of the above. Social workers, allied health, you think about, we have audiologists. I mean, you have so many different types of physical therapists, of healthcare professionals. It should be core in health professions education.
Okay.
Across all disciplines.
I couldn't agree more. And it's not. And John, you bring up community health workers. What a fantastic group of people to be able to get out there in our communities, work with people on mindfulness, cognitive behavior, skills building, other resiliency components that we know are protective against mental health disorders, but protective against cardiovascular disease. We have got to remember 80% of cardiovascular disease is preventable with just a few healthy lifestyle behaviors, including physical activity, 5 fruits and veggies a day, don't smoke. If you drink alcohol, limit it to 1 drink a day. And that's not size of the alcoholic beverages we get in Vegas. Add 7 hours of sleep on top of that and regular stress reduction practices. We literally could almost obliterate cardiovascular disease. So we've got to focus on this prevention, screening, early evidence-based interventions. For instance, in a primary care practice, we know deep abdominal breathing. We have so much research behind that using the 4-7-8 method really cuts the sympathetic response and lowers blood pressure, lowers heart rate. But again, most practices aren't screening for stress and teaching breathe, evidence-based interventions that we know work. We have a federally qualified health center here. My particular college, it's nurse practitioner-led, interprofessional, team-based, where we really take this holistic approach. We screen every single person for depression, stress, and anxiety, and integrate mental health into every routine visit that we have.
How common is that, Bern?
I think more practices, again, are starting to do more of this integration, but we have so much more opportunity in front of us. We have to remember people are still waiting 3 to 4 months to get in for mental health evaluations. But there's other solutions, like Cheryl and I just pointed out, that can be easily delivered in our communities, in our primary care practices. It is so key to solving, or at least helping, this current epidemic.
So I'm so glad you're covering all these bases because they all come together and they all have to. Cheryl, amongst our National Forum members who are here with us today virtually, we have groups who represent consumers and patients. We have providers. We have public health professionals and decision makers. We have payers. We have purchasers or employers. And we have pharma and biotech and other industries all here together. We've been talking, I think, mostly about changes that need to take place in the clinical setting and clinicians raising the priority on screening and treatment within their practices, and to some extent about consumers and patients here as well. Are there roles for public health and payers and employers? You mentioned the workplace earlier.
Excellent question.
How does all this fit together?
There are definitely roles for health educators and public health researchers because I love how Bern keeps bringing it back to the basics of health behaviors, physical activity, nutrition, and people hearing about all those things, eat healthy, exercise, sleep 7 hours, they might say, oh, right. How am I supposed to do that if I want to pay my bills, if I'm caring for my mother and my children? There are all these responsibilities that people have. We all have 24 hours in a day. How do we get this done? And I just really want to bring it back to mindfulness-based interventions. People may think that is such a, something that's in vogue right now and something's going to go out of style. But what is so beneficial about it is it actually helps people have the wherewithal and the ability to create space for these activities. We are often worrying, or we are spending time doing things that we're unaware that we're doing that could be time spent doing healthy behaviors or spending time with loved ones that bring us joy and laughter. There's mindfulness eating, mindful-based eating, because Bern mentioned earlier, eating as a coping strategy. It's a non-stigmatizing way to cope that's acceptable in our society, but we can become more aware of the behaviors we do so that we can change them. And anyone can do that if given the opportunity. I just wanted to emphasize that. We can make these behavioral health changes with public health professionals.
Thank you.
Cheryl, excellent points. I want to add, though, it's both of us work on this behavior change piece. Sadly, most people don't change unless crisis happens. They're diagnosed with some type of chronic disease, and then they say, oops, I think I should change. So what I advise a lot of primary care clinicians to do is make sure, because we think education so often leads to behavior change. It's important to raise awareness, but you gotta add emotional story to get people to change. People have to have this reason. And again, along with mindfulness, brief cognitive behavior therapy-based techniques like check and change your thoughts. There's some very brief evidence-based interventions that we can teach to really lower people's stress, help their depression, that if we did that routinely, we would improve high blood pressure and cardiovascular disease. It's got to be screened for and intervene preventatively and early.
Got it. Our time is drawing down here. This is such a fascinating and important conversation. I want to shift our focus in the remaining minutes to whether some people are more vulnerable or more at risk than others. We know that stress and anxiety are present in every single zip code in the U.S. We know that cardiovascular disease is in every single zip code. We also know that where you live, your zip code, is a more powerful predictor of your health than your genetic code is. And so I'm wondering that even though it is everywhere, are there places in our nation and in our communities where we see more anxiety, stress, and depression leading to more cardiometabolic disease?
I'm so glad you brought this up. You're approaching the topic of health inequities and our goal to achieve health equity. We have vulnerable populations who live in urban settings because we call them food deserts, or there's limited ability to find safe places to exercise. There are rural environments that have the similar limitations, but for different reasons. And then there are racial ethnic groups that have higher rates of cardiometabolic risk and need culturally sensitive interventions. And so we can't address this topic unless we understand and have sensitivity to the needs of those groups who need nuanced care to make sure we're addressing their health, behavior, and health and well-being needs. So thank you so much for bringing that up. And that's been my passion for research over the last several years. Thank you.
Well, and as Bern knows, as a member of the National Forum Board, our overarching goal is to eliminate cardiometabolic health disparities and achieve health equity. So what you're saying, Cheryl, certainly resonates with, I think, all of us who are gathered here today. Bern, you had a comment, I think?
Yeah, I just want to add to, though, mental health problems impact everybody across all socioeconomic status. And we have got to start integrating this more in the prevention and treatment of cardiovascular disease. Or else, again, we're not going to make the progress that we are so hoping to make. And I really want to thank you, John, and the National Forum for really raising visibility on this incredibly important issue.
I also want to say thank you, and I really do hope this can help influence integration of behavioral health care where we work, live, and play, schools, workplaces, communities, in our households. So thank you so much.
Well, thank you both very much. This has been a really enlightening discussion for me, and I hope for National Forum members as well. So thank you very much, Dr. Giscombe, Dr. Melnyk, for sharing your insights on the links between mental health and cardiometabolic health, and even more importantly, how we can raise the priority on diagnosing and treating these conditions. It has to be done.
Yes. Thank you.